Thank you, Margot. So I will kick off the talk with radionuclide imaging in amyloidosis, followed by echocardiography and cardiac MRI. So my talk will avoid touching these two, and we have experts on these two fields to come through quite shortly. So I'll try and share my screen if I may. Okay, let me just
Ashutosh, I can control them for you if you.
So would you advance the slides for me?
Yeah, I can advance for you.
Okay, great. So so the question is for us is why imaging in amyloidosis? What's the role? What's the purpose of imaging in amyloidosis? And could we have the next one, please? So essentially, the reason we need to image amyloidosis is the diagnosis of amyloidosis is based on, we could have the next two clicks as well, if I may. The diagnosis of amyloidosis is based on histology, where we demonstrate the evidence of amyloid deposits on Congo red. And then we use fibril sequencing or immunohistochemistry to type these amyloid deposits. Now, what that tells us is that there is amyloidosis. What that also tells us is where these amyloid deposits are present, but it doesn't tell us the extent of the amyloid deposits. It doesn't allow us to type the amyloid deposits, and it doesn't allow us to stage the patient. So imaging may allow us to do all of that and in a non-invasive way, and therefore imaging becomes critical to the diagnosis and management of amyloidosis. Next slide, please. Again, next one, please. So if you keep clicking on this one. So imaging in amyloidosis can be of multiple different types. It can either be related to radionuclide imaging or structural imaging. We'll hear later on about the cross-sectional structural imaging of echocardiography, cardiac MRI, and CT. Within radionuclide imaging, we can have tracers which are specific for amyloid, and we can have tracers which actually have some other roles, but then are useful for amyloid imaging by the way of their property to bind amyloid deposits, such as DPD, HMDP, PYP. Tracers which can image autonomic nerves, such as MIBG, and then metabolic tracers linked to FTG, ammonia, or rubidium, which can tell us about myocardial perfusion in amyloid. Next slide, please. So the imaging that we've been using here in the UK, which is probably the most widely used technique until the advent of PYP and DPD, was serum amyloid P component scintigraphy. This pentameric structure you see is known as SAP. It's a component of all amyloid fibrils binding to these amyloid deposits by non-covalent means. We can radio label the SAP with iodine. Can I have the next couple of clicks, please? And when this iodine is radio labeled and injected into a patient, it will bind to the amyloid deposits. We have now done over 40,000 scans over the last 25 years. And show that it's very useful for imaging amyloid in visceral organs such as the liver, spleen, bones, and soft tissues. Because it's not very specific, we don't find it particularly useful for the heart, the lungs, the nose, or the gut. We can track the amyloid deposits, we can see the amount of amyloid, and we can scan these patients serially to see whether the amyloid deposits are getting better or worse. Next slide, please. So this shows a typical SAP scan. This was a 48-year-old patient who presented to us with cardiac AL amyloidosis, abnormal liver function tests, had a biopsy which showed evidence of amyloid. He presented with spontaneous splenic rupture, and they had to operate an emergency, and he had factor 10 deficiency. So essentially what we would call an entire house of AL amyloidosis. And on the left-hand panel, you can see his SAP scan, which shows a massively enlarged liver, which is very hot with a lot of uptake and no blood pool uptake. This patient went on to get chemotherapy with a bortezomib-based regimen and got a complete response and had a dramatic improvement in his liver function test. And when we repeated his scan in 18 months, you can see that the amyloid has regressed. The liver is no longer as massively enlarged as it was. It is massively shrunken. We would normally see a spleen, but this patient, of course, had a spontaneous splenic rupture and had to have an emergency splenectomy. There's a hint of uptake in the kidneys, and then you can see a normal blood pool signal in the heart. So we can use this scan to track his amyloid deposits and then we can repeat these scans in the future to see whether the amyloid deposits are getting better or worse. Next slide, please. So this was a different patient. Again, you can see quite a lot of amyloid in the liver. You can also see a hint of uptake in his bones. Next slide, please. This patient went on to have, you can see that there is uptake in his spleen. The liver has gone back to normal. Next couple of slides. This patient then relapsed, and you can see that amyloid is reaccumulated in the liver. So we can use the SAP scan to track amyloid deposits in the visceral organs. Next slide, please. However, SAP scintigraphy is not very useful for imaging the heart, and therefore its role in imaging transthyretin amyloidosis, which is of course common and of special interest to here in the cardiology community. With wild-type ATTR amyloidosis, SAP scans are normal. With familial or mutant TTR amyloid, including V122I, we may occasionally see subtle uptake in the kidneys, but generally they are normal as well. Next slide, please. We can also do standard FDG PET in amyloidosis. Next couple of clicks, please. FDG is not taken up by amyloid fibrils, but it is often taken up by the tumor cells causing amyloid or soft tissue macrophages. Next slide, please. And FDG PET is useful in patients with localized type of amyloidosis. This is a patient with cutaneous amyloid deposits where you can see local hotspots of amyloid. In this patient, the SAP scan was normal. It is not particularly useful in cardiac amyloidosis. Next slide, please. And this is another patient with localized amyloidosis showing FDG uptake in the chest in a patient with a thoracic amyloidoma. Next slide, please. This is a different patient with a large lung amyloidoma showing a bit of calcification with low-level FDG uptake, and this patient had a Waldenstrom's macroglobulinemia causing this massive amyloid deposit. Next slide, please. The compounds which are of great interest in imaging cardiac amyloid are the so-called thioflavin-like compounds. Congo red is a thioflavin-like compound, and these are compounds which bind to Congo red, and these are C11PIB, flubetabel, and flubetabel. Next slide, please. These have been licensed for brain imaging, and with these, we can see very specific cardiac uptake. It seems to be there for both AL and ATTR. It seems to be more in AL amyloidosis than ATTR amyloidosis. Next couple of clicks, please. This was a study by Shamina Dovala and colleagues from Boston, and you can see on the dot plot on the right-hand side that the uptake was much greater in patients with AL using flubetabel compared to ATTR compared to controls. And at bottom is a series of scans with flubetabel, which is a similar tracer showing cardiac uptake in patients with AL amyloidosis. Next slide, please. Flubetabel has been further studied in amyloidosis, and this was a study from an Italian group which looked at a series of patients with AL amyloidosis, where you can see that there's significantly greater retention of flubetabel in AL amyloidosis compared to ATTR amyloidosis or no cardiac amyloidosis. Next slide, please. And what they were able to show was that when you track these patients serially, the initial uptake in AL and ATTR is there, but in ATTR amyloidosis, as well as in controls, the tracer clears out of the heart much more quickly than it does in AL amyloidosis. So if you were to scan a patient with flubetabel at, say, 40 minutes following injection or an hour following injection, as you can see on the right-hand panel, there's retention in patients with AL, the top picture, but no retention in ATTR or in controls. So potentially doing an early scan and a late scan, we could differentiate between AL and ATTR amyloidosis. Thus far, this tracer seems to be very sensitive for amyloid imaging, and there have been very few false negatives. Next slide, please. Next slide, next few clicks on this slide. So flubetabel, we did a study with flubetabel, and what we can show that in addition to imaging the heart, we can also see uptake on these, this slide on various other organs, such as the stomach, the liver, and the tongue, as well as lungs in a patient with AL amyloidosis. So it may be helpful to image amyloid elsewhere, but its main role is still cardiac imaging. Next slide, please. We also found flubetabel uptake in a patient with localized amyloid where there was uptake in the lymph nodes. Next slide, please. Patients with amyloidosis often get significant neuropathy, and autonomic neuropathy can cause cardiac dysfunction, particularly bradyarrhythmias or changes in heart rate, and detecting autonomic dysfunction is quite important. MIBT has been reported to be helpful in diagnosing autonomic dysfunction in patients with familial amyloid neuropathy. This may be very important now that we've got agents which can treat ATTR amyloidosis, such as drugs which stop synthesis of TTR amyloid in the liver, such as patisiran and inotersen, and tracking improvement of autonomic neuropathy using this imaging would be an interesting study. This has been studied at baseline in patients with V30M and other types of amyloid neuropathy, but studying MIBG uptake in patients following treatment would allow us to track improvements after therapy. Next slide, please. There are a number of other new agents, which are small peptides, which are being studied, such as AT01. This is a small peptide which can bind to all types of amyloid fibrils in a sort of covalent way, very similar to what we see with SAP. These are a couple of scans from patients who have been imaged with this particular agent. And you can see that there is uptake in the liver, spleen, and kidneys with this particular agent. And in the second scan, you can see that the liver uptake has improved. In a small number of patients that were studied with this particular agent, cardiac uptake was seen in 70%, renal uptake in 89%, with a sensitivity of 93% and 100% cardiac specificity. The specific advantage of this agent over almost all the other agents that we have heard so far is that it is agnostic to the type of amyloid. It will image all kinds of amyloid because it binds to the fibrils rather than a specific amyloid protein. It will bind to AL and ATTR and help us to diagnose both conditions, although we don't know how we could differentiate one from the other using this particular tracer. Next slide, please. Next slide, please. The other thing we find with amyloidosis is that these patients often have significant problem with their coronary perfusion. We don't quantify it very well. The patients don't get chest pain, but if we can do perfusion reserve measurement using PET and lately using MRI perfusion, we can show that there is a significant reduction in the coronary flow reserve in patients with amyloidosis. This appears to be true for both patients with AL amyloidosis and ATTR amyloidosis. As you all know very well, that the troponin levels are very high in patients with amyloidosis, and one wonders whether it's chronic ischemia that leads to high troponin amyloid, and if we can have strategies to target this, whether we could reduce the risk of arrhythmias and sudden cardiac death in patients with amyloidosis. At present, we have no way of treating this, and indeed we don't monitor this, but we do need to think about looking for this in patients where you're seeing unexplained chest pain with normal epicardial coronary arteries. Next slide, please. And then, of course, we've got DPD scintigraphy, or PYP scintigraphy, which I don't need to tell you about, highly sensitive for imaging transthyretin amyloid deposits, very few false negative scans. And in absence of any monoclonal protein, you can diagnose ATTR amyloidosis without a biopsy. Next slide, please. However, it is very important to remember that DPDs or PYP is also taken up by patients with AL amyloidosis. This is a paper that we've just published in European Journal of Heart Failure, Cardiovascular Imaging, that patients with ATTR, AL amyloidosis can have uptake, including a quarter of the patients having grade 2 cardiac uptake. So just having a positive scan doesn't mean this is ATTR amyloidosis. Next slide, please. And what we were able to show that in patients with AL amyloidosis, if they get a good response to treatment, the DPD scans actually got better. This is a patient at diagnosis and 2 years after therapy showing improvement in DPD scintigraphy. And we have got some anecdotal information that the same happens in TTR patients following treatment. Next slide, please. So we presented this diagnostic algorithm that if you have got a grade 2 or greater DPD scan, we need to look for presence of a monoclonal protein. If there is a monoclonal protein, then in a younger patient, we do require an endomyocardial biopsy to confirm that this is AL amyloidosis to differentiate it from ATTR amyloidosis. Conversely, if the patient has a low-grade DPD uptake, such as a grade 1 uptake, then it's very unlikely to be ATTR amyloidosis. If you have got a monoclonal protein, we could simply do any peripheral tissue biopsy to confirm AL, but if we don't have a monoclonal protein, then we still need an endomyocardial biopsy for confirming diagnosis. On the other hand, if you have got grade 2 uptake and no monoclonal protein, then it fulfills the non-biopsy diagnostic criteria as published by our colleague Julian Gilmore in a global collaboration and confirms the diagnosis of ATTR amyloidosis. Next slide, please. In AL amyloidosis, DPD appears to be prognostic. Patients who have DPD positivity have much poorer outcomes than patients who are DPD negative. We don't understand the mechanism of DPD uptake. Next slide, please. And in ATTR amyloidosis, colleagues from Boston were able to show that there was small microcalcification within the cardiac amyloid tissues, and one wonders whether this is the source of DPD uptake or PYP uptake. Next slide, please. In AL amyloidosis, this microcalcification wasn't present, And we wonder whether the reason for DPD uptake is actually injury to the myocyte and calcium leakage from the damaged myocytes. Next slide, please. Next slide, please. Next slide. So to summarize, cardiac uptake on a DPD or PYP scan means amyloid until proven otherwise. There are very few false positives. It may be any kind of amyloid. If there's no cardiac uptake on a DPD, it does not rule out amyloidosis. And next click, please. And cardiac uptake on DPD does not automatically mean ATTR amyloidosis. Please think of AL amyloidosis, and if it's grade 1 uptake, you could have rare familial types of amyloidosis. Next slide, please. This is critically important now that we've got treatments. This is a patient who was treated with anti-SAP therapy, and you can see that amyloid can regress from the liver, but we also need cardiac imaging, and therefore imaging would be a very helpful non-invasive modality to check for amyloid improvement or worsening. Next slide, please. So to conclude, amyloidosis is mainstream. PYP DPD scintigraphy has changed the diagnostic algorithm for amyloid diagnosis in ATTR, but negative scan does not rule out ATTR. SAP is only done here in a few centers, but still is a very routine tool. And now we've got a number of other tools, flu-beta-PIR, flu-beta-Ben, and AT01, which may be pan-amyloid intermediates. Next slide, please. Thank you very much for listening, and thank you to all my colleagues.
Thank you so much. There's one question in the chat that, I don't know what your opinion would be on it, but it is, for relatives of a patient who has amyloidosis, are any of these imaging tools expected for screening for family members of somebody that has a history or a family member that had amyloidosis?
For somebody whose family member has amyloidosis, I would do their genetic screening first to check whether they have the mutation or not. And if they have a mutation, such as V122I, and they are at the age where this type of amyloid presents, for example, in their 6th decade of life, then there may be a role for undertaking screening to detect amyloid deposits early, especially as we now have treatments which can prevent amyloid progression. And all treatments are licensed for symptomatic amyloidosis and not asymptomatic disease. But it won't have a role for screening a patient where we did not have this mutation.
And then do you see any familial tendency in people that have AL amyloidosis?
So there are two answers to this question. One is Merrill Benson and colleagues from Indiana reported a rare familial form of AL amyloidosis, which is because of a kappa mutation, and these patients don't have a monoclonal light chain. It's a familial kappa light chain amyloidosis. We've got a family here in the UK as well. So there's very rare familial AL amyloidosis. And then there are occasional families where there's a high risk of monoclonal gammopathy, which seems to run in families where they get AL, but in general, AL is not hereditary.
Thank you so much. That's great.
Hello, I'm Carol Whelan.
Right, so
I'm a
Dr.
consultant cardiologist at the National Amyloidosis Centre in London, UK. I'm delighted to talk about cardiac imaging pearls and in particular echocardiography in diagnosing cardiac amyloidosis. These are my declarations. Amyloidosis is a disease caused by amyloid deposits, localized or systemic. Systemic amyloidosis is usually fatal, and it causes about 1 per 2,000 deaths in the UK. Diagnosis and treatment have been difficult to date. There have been major recent advances, however, and better outcomes, but we note it is still a major unmet medical need. The types of amyloidosis affecting the heart are AL, or light chain, and TTR, transthyretin, which can be wild type or acquired, or hereditary. Wild-type transthyretin is increasingly being recognised as a cause of HFpEF, or heart failure with preserved ejection fraction. The number of patients that we have been diagnosing at the NEC has grown considerably over the last 20 years, particularly with the advent of new imaging modalities such as CMR and DPD, which you'll hear more about. It is typically affecting men. 94% of the patients are male over the age of 50. Carpal tunnel syndrome is common, and ATTR amyloid deposits are present in around 25% of men over the age of 80, but often it is not diagnosed in life. Hereditary ATTR amyloidosis tends to be a spectrum of predominantly neurologic to cardiac phenotype, depending on the variant. Worldwide, T30M associated ATTR amyloidosis is the most prevalent and can have early onset and late onset, causing a neuropathy and or a cardiomyopathy. T60A associated ATTR amyloidosis is most prevalent in British Caucasians of Irish descent, and Donegal is a particular hotspot. And V122I TTR variant is present in around 4% of African Americans and is increasingly recognised as a cause of heart failure. To diagnose cardiac amyloidosis, we should look at an ECG, echocardiogram, CMR, DPD scintigraphy, and if necessary, a biopsy. I'm going to concentrate on ECG and echo. We're taught at medical school that if a patient has amyloidosis, they may have small complexes on the ECG, and we can see this to the left of the screen with the small complexes in the inferior leads. But a low voltage is only found in around 50% of patients with AL. It is also seen in about 25% of patients presenting with ATTR amyloidosis. But around 50% of patients with AL amyloid have a pseudo-infarct pattern, i.e. suggestive of a previous infarct when they haven't. This is more typical of an ECG in TTR amyloidosis with large complexes, so that can sometimes put clinicians off. Here's the parasternal long axis view on the transthoracic echocardiogram. The probe is near the top of the screen, and we can see that the right ventricle free wall is thickened, as is the interventricular septum and the posterior wall. The left atrium is dilated, and there's a small rim of pericardial fluid, which is common. This is the 4-chamber apical view. Everything's upside down. The probe is on the chest at the top of the screen. And we can see there's biatrial dilatation or an Alzheimer's appearance with thickening of the right ventricle, interventricular septum, and left ventricle, thickening of the valves and the interatrial septum. These are typical appearances of amyloidosis. In this moving video, we can sometimes be lulled into a false sense of security about the overall heart function because the apex typically is spared and functions to a degree normally. But it is the longitudinal function that causes the problem. And we can see here there's very little longitudinal function in this heart. This is typical of amyloidosis, and we can use this information to get the longitudinal strain, which is impaired in cardiac amyloidosis. This can be measured after the routine study. It is very straightforward to do. The measurements can be then taken offline. So as I said, the contraction of the heart is complex with longitudinal contraction, radial contraction, and long axis deformation and twisting. So when we look at this and the longitudinal strain, on the left-hand side of the screen, we can see a normal strain pattern where the measurements are all very similar around the left ventricle. But on the right-hand side of the screen, we can see that there is this bullseye appearance because of apical sparing. So the apical function is normal, but the longitudinal or basal function is impaired, causing the global strain to be half of what it should be. It should be around -20%, and in this patient, it is only -10%. And this is a typical strain pattern of cardiac amyloidosis. Other conditions don't give this appearance. We have published recently that longitudinal strain is an independent predictor of survival and response to therapy in patients with systemic AL amyloidosis, led by Oliver Cohen, my colleague. We can see on the left-hand side of the screen that worse longitudinal strain at presentation is associated with higher early mortality and poorer overall survival. So if someone's longitudinal strain is around -16%, their survival is much, much better than those with a longitudinal strain of -9% at presentation. In addition to this, we can track the strain during treatment, and we can see on the bottom left-hand part of the screen that the red line is those patients where the longitudinal strain has improved by at least 2%, compared to the blue line where the longitudinal strain has not improved by at least 2%, and there's a significant difference in the overall survival in the two groups. We therefore propose that there's a new staging system for cardiac AL, which involves the measurement of the longitudinal strain. Stage 1 is when the NT-proBNP is less than 332 nanograms per litre and the troponin is less than 0.035 nanograms per litre, and the longitudinal strain is -16% or better. Stage 2 is when the NT-proBNP is more than 332 nanograms per litre, but less than 8,500 nanograms per litre, or the troponin is more than 0.035, or the longitudinal strain is between -16 and -12. Stage 3 is when the NT-proBNP is again more than 332, but less than 8,500, and the troponin is more than 0.035, or the longitudinal strain is between -9.1 and -12.1. And lastly, stage 4, where the NT-proBNP is greater than 8,500 and the troponin is more than 0.035, or the longitudinal strain is -9 or worse. And this then allows us to propose a new treatment response criteria where stringent cardiac response is where the NT-proBNP decrease of more than 30% and 300 nanograms per litre, and the longitudinal strain has improved by -2% or more. A cardiac response is where there's an NT-proBNP decrease of more than 30% and 300 nanograms per litre, or a longitudinal strain improvement of more than 2%. Stable cardiac disease is where there's a decrease in the NT-proBNP, but it's less than 30% or 300, and the longitudinal strain improvement is less than 2%, or indeed where there's cardiac progression and there's worsening of the NT-proBNP or worsening of the longitudinal strain. This is taken from the expert consensus recommendations for the suspicion and diagnosis of TTR cardiac amyloidosis, but many of these clues can be used for AL amyloidosis too. So, for instance, HFpEF, or heart failure with a preserved ejection fraction, particularly in men, because it's normally more common in women. If the patient is intolerant to normal heart failure drugs such as ACE inhibitors or beta blockers, bilateral carpal tunnel syndrome or lumbar spinal stenosis, unexplained atrial arrhythmias, unexplained peripheral neuropathy, and then the imaging clues, such as the apical sparing on longitudinal strain imaging, or restrictive LV filling with the RV wall thickening, and combined clues such as heart failure with unexplained increased LV wall thickness in a non-dilated left ventricle, or depressed longitudinal function despite a normal ejection fraction. So in conclusion, early diagnosis of amyloidosis is essential for patients to gain the most benefit from treatment. There are several red flags that raise suspicion of the diagnosis, and there are several ongoing clinical trials in AL, wild-type ATTR, and hereditary ATTR amyloidosis, and there are now licensed treatments. Thank you very much.
Thank you very much for this invitation to speak. It's a pleasure for me to be here today. So in the next 10 minutes, I'll briefly talk about CMR in cardiac amyloidosis. This is my disclosure. Thank you very much for this invitation to speak. It's a pleasure for me to be here today. So in the next 10 minutes, I'll briefly talk about CMR in cardiac amyloidosis. This is my disclosure. So I'd like to start with what is wrong with what we have in imaging in cardiac amyloidosis. So the first problem is that I do not think that our imaging is precise. So let's have a look at what we do in clinical practice. We all have measured the wall thickness. And here what we ask is, we ask 10 clinical experts, international recognized clinical experts, to measure the maximum wall thickness on this image. And you can see that there is a lot of scatter, almost 1 centimeter. So we have a problem because we are basing our treatments on something that we do not agree with when we measure it. So current wall thickness is an acceptable measure as a clinical test, but yet we all use it in clinical practice to define disease. The second problem is that the approach we decided to use to define cardiac pathology is to assess the structure and function. The problem is that by defining pathology based on structure and function, and a beautiful example is, for example, hypertrophic cardiomyopathy, which is an increase in wall thickness of more or equal than 15 millimeter in the absence of loading condition. The problem is that by choosing this approach, we are extremely far from the underlying mechanism which is responsible for the clinical phenotype and drives disease progression. The third problem is that our link to treatment is very poor. In oncology, this is very different. In oncology, we've got a beautiful example of treatments which target specific pathways, and imaging modality can actually visualize and follow and track changes over time over that specific pathway. What we do in cardiology is very different. When we think, for example, about ejection fraction, we all live with the fact that different imaging modalities, different machines, different operators will give us different results, different values, but we all use specific cut points to make decisions which are important for the society and also for patients, like, for example, ICD implantation. So where are we with CMR as concern these three problems? I will start from diagnosis. So it was the early 2000s when we started to give gadolinium to all sorts of different people with different diseases, and we kept finding different patterns. And what we learned is that this process of finding different patterns was extremely useful in assigning a specific diagnosis, a process which is known as phenotyping. And then we learned roughly 15 years ago that after giving contrast to patients with cardiac amyloidosis, we could get pictures that were extremely typical. And these were what we call orthogonal kinetics. So the blood was black as opposed to gray, because there was so much amyloid within the myocardium that the contrast was going quickly out of the blood into the myocardium, and then this line of subendocardial or transmural enhancement would appear. And these images were felt to be very typical of cardiac amyloidosis. But whilst legal enhancement is extremely useful to to assign a diagnosis, what about tracking changes over time? And here I would just like to underline the difference between accuracy and precision. When we see a patient for the first time, what we want to know if the patient has got the disease or not, and this is an accuracy question. But actually, when we see a patient after the first time, so the second or third time, what we want to know if the patient is better or worse or is stable with or without treatment. So the question is then very different, is not what the patient has, but if the patient, how do the images now compare to before? And this is not anymore an accuracy question, but a precision question. And why is that important? Because imaging modalities or parameters that can have a high accuracy may have a very bad precision. So then legal enhancement is extremely useful to assign a diagnosis, but what about tracking changes over time? This is a patient with ATTR amyloidosis associated with RMB122I, and these images are taken 3 years apart. And you will all agree that it's very difficult just based on these images to say if the patient is better or worse. But can we overcome this problem? So there is a technique called T1 mapping that has been around now for more than 10 years that can help to overcome some of this limitation. So what we do in this patient is that we acquire one T1 map before contrast, so one breath hold. Then we give contrast that goes in the extracellular space. And by repeating the same sequence after contrast, what we get is an extracellular volume map. So a pixel by pixel quantification of extracellular volume. But why extracellular volume maps are relevant in amyloidosis? Because the amyloid sits in the space between the cells. So the higher the amyloid burden, the higher will be the extracellular volume within the myocardium. So then can we go with CMR from assigning a specific diagnosis with legal enhancement to try to image biology and measuring specific pathway? And in the more specific case, we try to measure the cardiac amyloid burden. And we do that with T1 mapping. So here are two patients with ATTR amyloidosis, same increase in LV mass. You can already notice that on the non-contrast T1 map, there is some difference. The patient at the bottom, T1 is higher. And on the legal enhancement, probably the patient at the bottom, the myocardium is more wide. But the difference with the extracellular volume map is actually striking. The patient at the top, the extracellular volume is 39%. The patient at the bottom, more than 60% of the heart is actually amyloid. So same increase in LV mass, same decrease of systolic diastolic failure, but the amyloid burden is very different. So these patients are at a very different stage of disease progression. And if we go back to the image I've shown you before, but now instead of showing the laggard, I show you the extracellular volume map, you can see that actually the difference is striking. On the left, the myocardium is green, on the right, the myocardium is red. And by drawing a simple region of interest, you can see that there has been a significant increase in the extracellular volume from 45 to 67%. And because the extracellular volume is a measure of the amyloid, it's not surprising that predicts with prognosis in both types of amyloidosis. So we can measure the amyloid burden in the heart, but also in the liver and the spleen, because when we acquire the image for the heart, we usually get the liver and the spleen. And by simply drawing a region of interest, then we can get information on the amyloid load within the liver and the spleen. You can see on the left is a patient with no amyloid in the liver and the spleen, these are blue. And on the right, this is a patient with a large amyloid load in the liver and the spleen, and these are both red. But then, can we link our imaging to treatment? So this is a preliminary analysis from a study in now more than 150 patients with a yellow amyloidosis who were imaged at baseline and then 12 and 24 months. And what we learned from this population that actually the percentage of patients with amyloid progression was quite high. So 32% of patients would get amyloid progression over time. But what was also important that we noticed that all patients with amyloid progression were in a deep hematological response. So getting a deep hematological response is important then to be able to regress, but not all patients with a deep hematological response would regress. So CMR is really adding additional information on top of the hematological response that the patients achieve. And this is a beautiful example of this concept. At the top is a patient where before treatment, characteristic images of cardiac amyloidosis. You see that the myocardium is white and the blood is black. 1 year after, there is almost complete regression of the amyloid. The LG has normalized and the extracellular volume has gone significantly down. But what about TTR then? This is the results of a study of 16 patients who were treated with patisiran, so a drug that is able to reduce the TTR production by 85 to 90%, compared to 18 patients not on treatment with any disease-modifying treatment. And what we noticed is that patisiran was typically associated with a reduction in ECV with an adjusted mean difference between group of minus 6.2%. And this one is an example. So at the top is baseline, at the bottom is 12 months after. You can see that lots of blue dots start to appear in the myocardium, and this corresponds with a decrease in the extracellular volume. So in summary, the clinical impact of CMR is because we are really imaging the disease substrate. And this is extremely helpful to assign a specific diagnosis. So with LG, we visualize the disease and we can assign a diagnosis. But with mapping, we understand and measure specific processes. And we can also use mapping to track changes over time. So shall we use CMR in all patients? The question is really not what is the best imaging modality, but which is the best and most appropriate at each step of the imaging pathway. Thank you very much for the attention.
So we've seen that there's been enormous evolution of echocardiography and cardiac amyloidosis, starting with historically comments on speckled myocardium to now where we can do strain imaging and really identify amyloidosis with a fair degree of specificity. Echo, of course, has great advantages. It's highly accessible. And so really the role of echo in amyloidosis at this point is best suited to being a first-line imaging modality, useful for identifying patients who really require further investigation. I think that every imaging modality really does have its most precise role. There's no one imaging modality that's going to be good for everything. So cardiac MRI, of course, its strengths are that it's a highly accurate diagnostic tool. So cardiac MRI, of course, produces high quality images and can provide tissue characterization. It has high sensitivity and specificity for cardiac amyloidosis. With extracellular volume fraction, we're able to quantify amyloid burden to some extent. And of course, there are numerous prognostic markers identified. So while cardiac MRI cannot truly replace a biopsy, it can provide diagnostic accuracy that may be greater than some of the other modalities, and really beautiful images, of course. And of course, there's native T1 mapping, which does, when appropriately read in centers with some experience, there can be high sensitivity and specificity of T1 mapping, even without contrast, which may be very useful in patients who have renal dysfunction that limits the ability to get contrast. Nuclear imaging, of course, is an essential part of our diagnostic pathways. We've heard from Dr. Wachalkar about the multiple novel imaging modalities, or novel tracers rather, that are on the horizon that can offer maybe much more than this. But at this point in time, nuclear imaging, whether it's DPD or pyrophosphate, offers reasonable and better than other modalities discrimination between AL and ATTR, which of course is very important. It has revolutionized the diagnostic pathways in ATTR and removed our dependency on endomyocardial biopsy in cardiac amyloidosis. As you've heard, there are numerous isotopes with specific strengths and roles in nuclear medicine, and there's an opportunity for some of these novel or emerging isotopes to further streamline our diagnosis and, of course, monitor response to therapy. So where can we go from here? Where are the pitfalls? Where are the limitations of each of these modalities? Well, in echo, at least in our center, the biggest problem with echo is just having GLS routinely done in patients. The tool is only useful if it's used. And I think other centers have struggled with this as well, is getting routine measurement of strain and screening for that apophospheric pattern in patients who have increased wall thickness on their 2D echoes. In MRI, one of the biggest limitations, I think, in many centers is simply access to scanners. Not all centers, of course, have them. Not all centers have the ability to do T1 mapping or extracellular volume fraction measurements. And often there is a delay in getting access to these scanners, which can reduce their clinical utility. And of course, MRI at this point in time, although there are markers that have been identified that may help to discriminate between ATTR and AL, I don't think we're there yet where they can be routinely used to make that differentiation. And finally, in nuclear imaging, I think there are opportunities to move in both directions, and you've heard about these in today's presentation. There's an opportunity to start using markers that offer even better discrimination between AL and ATTR. And for universal amyloid binding isotopes for broader use and whole body imaging. Right now, when we're talking about cardiac amyloidosis, we really are limited to those bone-seeking radiotracers, DPD and PYP. I think, though, in all modalities, I think that really a huge part of the future of imaging is going to be in monitoring response to therapy. We're at a wonderful time in the amyloidosis journey where we are seeing many effective therapies for both AL and ATTR. And it's going to become really important to be able to monitor patients' responses to that, to understand whether the patient is on the best therapy, whether we should be stopping and trying something else. Because as you all know, many of these therapies come with significant price tags, and we want to be sure that we're using them appropriately. And so, you know, there are some studies that have shown the utility of each of these modalities in doing this. I think echo, of course, is going to be the crudest one, but we have seen that patients with AL amyloidosis will have changes in their cardiac structure seen on echo as they undergo therapy. And so this is just one example of patients showing a reduction in their wall thickness after stem cell transplant in responders, but not in the non-responders, and that of course correlates with survival. We've seen already in Dr. Fontana's presentation the utility of LGE and extracellular volume as measures of progression or response in AL. And again, as you can see here, in patients who progress, you can really nicely see that on these images, and similarly the patients who are responding. And in ATTR, of course, we can also see this. So this is a study, again, that you've seen already today, I believe, but of patients receiving tafamidis. And so you can see before and after tafamidis changes in native T1 mapping and extracellular volume measurements. And similarly, here's a patient who responded to patisiran with ATTR, and you can see a measurable reduction in extracellular volume as well as some other measurements on the MRI. And then, of course, there is SAP, which I think you've seen this exact slide already today, but showing the regression of AL in visceral organs after anti-SAP antibody therapy. This particular therapy has not gone further, but I think this is really going to be exciting as we go forward and develop novel therapies for AL, being able to monitor the regression of amyloid deposits, which I think, of course, is really our holy grail in amyloid therapy. And this is important, of course, because of the sheer number of therapies that are available or coming available. We've got the anti-TTR monoclonal antibodies, and in addition to the anti-SAP monoclonal antibodies that I've just discussed, we've got CRISPR coming, and so there's a lot of exciting therapies, but probably expensive therapies, and it's going to be really important to be able to monitor the response to therapy, because of course right now when we're treating patients with tafamidis for their ATTR, for instance, it's really hard to be able to demonstrate whether a patient is truly responding or not. So in summary, echo, MRI, and nuclear imaging each have unique strengths that suit them to different roles in the evaluation and management of patients with cardiac amyloidosis. Despite rapid advances in each of these fields, there are ongoing challenges that limit widespread applicability. And so we do still need to use biopsy in many cases. The role of imaging in monitoring disease progress and response to therapy is still evolving, but I think this is going to be an important aspect of future amyloidosis management. I'd just like to remind everybody that in the chat there have been your post-test questions, so please feel free to answer those questions and obtain your CME credits. We are grateful for educational grants offered by Janssen, Pfizer, and Eidos.
Thank you so much, Margot. That was a great summary. There was one question in the chat from Dr. St. Pierre. I'm not exactly sure where Dr. St. Pierre is from. But nonetheless, the question was, for GLS improvement during treatment of AL amyloidosis, is it absolute or a relative change?
I'm not sure if Dr. Whelan is on and can comment on that specifically. I think that that either absolute change or relative change would, if you're seeing improvement, would be welcome. And I think it's also important to keep in mind that different machines and different software packages will sometimes report strain differently. So when you're looking at those changes, it's important to make sure that you're comparing apples to apples.
Yeah, that's a key point. The other thing is, Doctor, you may have been already about to say something, so sorry to interrupt you there, but I was going to ask the next question, which is, in the treatment of AL, so when you're monitoring treatment response, most of that decision is based on hematologic measurements, and documenting an organ-specific response is very challenging. So I don't know if what you were about to say has anything to do with that.
So I think you're absolutely right, as our treatments are driven by the hematologic response measured by free light chains. but the organ response becomes crucial in patients who don't have a true complete response to therapy. So if you get a less than complete response, then tracking that their organ function actually improves is critical to deciding that the depth of response is enough and that they don't require more therapy. I was going to make a quick comment on the GLS. We've just recently published our data from a large AL cohort in European Heart Journal. It's just, I think, just become available online, where we've shown that an improvement in GLS by 2, an absolute improvement of 2, was associated with improved outcomes. The only group of ALs where we actually saw that improvement was patients who achieved a complete response to treatment. We didn't see the improvement in any other group of patients. That highlights the need for really deep reduction in light chains, and GLS certainly is a crucial marker in helping us, along with the other imaging modalities that we've discussed.
And I'd just like to add one last thing to that question, which is about the organ response. And certainly during upfront treatment, you're looking for initially the hematologic response and hopefully followed by an organ response. But if we're able to get to the point where we're able to offer therapies that will sort of lead to resorption of the amyloid deposits after treatment of the plasma cell dyscrasia, once the light chains have been normalized, then that's where you're going to need to be able to follow organ amyloid burden in the organs more than the light chains themselves.
Yeah, I think so. One of the areas where I'm constantly debating with my hematology oncology colleagues about this issue is in somebody who is being treated for AL, and it seems as though they're getting a response. It may not be a complete response, and I know there's many different stages of description of what that response might be. But when you get a sense from a cardiology point of view that the cardiac issues are progressing, is there a way that you can calculate or estimate that you have to change your therapy for AL because the organ, in particular the heart, is getting worse? Do you have any way of making that calculus?
That's a very difficult one to answer because there isn't a single marker, because NT-proBNP, which is one of the markers of response, is affected by all the drugs we give and the fluid status of the patient, so it fluctuates all over the place during therapy. We find that certainly in our practice, we use echocardiogram with GLS and MRI with contrast as the two important modalities where we are trying to figure out what's going on. And we have certainly found that the extracellular volume fraction that Mariana mentioned in her talk is a very useful and sensitive tool for seeing the change in amyloid load. Now, what we find also is the trajectory of the light chains to make that decision. If the light chains are dropping very quickly, then we may not change therapy even if the patient is slightly worse, because we could see that therapy will lead to a complete response. On the other hand, if we have not achieved a complete response within, say, 2 months of treatment and the patient is clinically worsening, that for me would be a very hard indication to change treatment. Very often symptoms would predate any of these changes. So a lot of it is based on patient symptoms, diuretic requirements, blood pressure, and imaging.
Right, and then do you include the cardiac biomarkers in your calculations there as well, because those do determine stage, at least in AL?
So we look at them, but we don't necessarily use them to make a response, because what we find is that when the patients are on treatment, every patient's biomarkers go up, and sometimes quite a lot. So they will give us, if they're consistently going up and progressively going up, that would be a strong signal that whatever we're doing is not adequate. But if they are fluctuating, going up and down, then we may take them with a bit of pinch of salt, because that may be more linked to their fluid retention and diuretics rather than true worsening of the heart disease.
Fantastic. So yes, basically you just answered one other question in the chat box from Dr. Fioretti in Bari, Italy. And just to mention that Dr. St. Pierre, who asked the other previous question, is from Montreal. So just to make sure we have the right locations for all these great participation. Well, thank you all so much. This has been a really fantastic presentation, and the combination of really expert presenters all of these disciplines has just been really unbelievable. And I especially give great thanks to Margot for getting up so early, since it's quite early in Vancouver. So, but in any case, thank you all for your participation. This has been a really wonderful series of presentations, highly educational, and we really like hearing from all these experts. Thank you so much.
Thanks, Dan.
Thank you, Dan.